Lantheus Medical Imaging welcomes you to a whole new dimension in MRA with steady-state imaging. Is it time to take back the reins in the diagnosis of peripheral vascular disease? A series of lectures delivered as part of a panel discussion at the 19th Annual International Society of Magnetic Resonance in Medicine meeting in Montreal, Canada. Before we begin, here is some important safety information for Ablavar. Indications. Ablavar is indicated for use as a contrast agent in magnetic resonance angiography, MRA, to evaluate aortoiliac occlusive disease, AIOD, in adults with known or suspected peripheral vascular disease. Contraindications. History of a prior allergic reaction to a gadolinium-based contrast. Warning: nephrogenic systemic fibrosis, NSF. Gadolinium-based contrast agents, GBCAs, increase the risk for NSF among patients with impaired elimination of the drugs. Avoid use of GBCAs in these patients unless the diagnostic information is essential and not available with non-contrasted MRI or other modalities. NSF may result in fatal or debilitating fibrosis affecting the skin, muscle, and internal organs. The risk for NSF appears highest among patients with chronic severe kidney disease, GFR less than 30 milliliters per minute, or acute kidney injury. Screen patients for acute kidney injury and other conditions that may reduce renal function. For patients at risk for chronically reduced renal function, e.g., age greater than 60 years, hypertension, or diabetes, estimate the glomerular filtration rate, GFR, through laboratory testing. For patients at highest risk for NSF, do not exceed the recommended Ablavar dose and allow a sufficient period of time for elimination of the drug from the body prior to readministration. Ablavar injection. As with other contrast media, the possibility of serious or life-threatening anaphylactic or anaphylactoid reactions, including cardiovascular, respiratory, and/or cutaneous manifestations, should always be considered. As with other paramagnetic contrast agents, caution should be exercised in patients with renal insufficiency due to the possibility of further deterioration in renal function. In clinical trials, a small increase, 2.8 milliseconds, in the average change from baseline in QTc was observed at 45 minutes. These QTc prolongations were not associated with arrhythmias or symptoms. Caution should be used in patients at high risk for arrhythmias due to baseline QTc prolongation. Have emergency resuscitative equipment available prior to and during Ablavar administration.
Thanks, Lantheus, for inviting us all here and giving me the opportunity to discuss the role of MRA versus other techniques in the evaluation of peripheral vascular disease. And now there is an enormous body of evidence supporting the utility of MRA. And I don't have time to get into all the papers. We're going to focus primarily on the review articles and meta-analyses. I'm disclosing patent agreements with all the major manufacturers of MR equipment and contrast agents. And of course, gallium is approved for aortoiliac MRA. Now, back in the early 90s, the non-invasive technique that was getting published for the evaluation of peripheral vascular disease was duplex ultrasound, shown in blue. And when MRA came along and contrast-enhanced MRA in the pale yellow, it really expanded and grew and pretty much took over. CTA papers are shown in green, and there's been much less documentation of the utility of CTA compared to MRA. Yet, in spite of that, if we look at the number of procedures that are done in the United States for the past 3 years, you could see that CTA for peripheral vascular disease is really dominating over MRA. The past year, nearly 3 times as many CTAs, in spite of really a lack of evidence compared to what's available for MRA. And I'm just going to briefly review a host of very impressive meta-analyses that have been done over the past 10 years to give you a sense of this degree of evidence in support of contrast MRA. Here a paper from Neilman's showing contrast MRA to be superior to time of flight with an order of magnitude greater diagnostic odds ratio. That's the odds of positive result when disease is present divided by the odds of a positive result without disease. And Visser and Hunnick, also about 10 years ago, showing contrast MRA superiority over duplex ultrasound with higher sensitivity and specificity. And here Colomé showing superiority of 3D gadolinium MRA over 2D MR techniques. Now, a more recent meta-analysis employing higher quality papers just published last year in the Annals of Internal Medicine, looking at 32 prospective studies, concluding these 32 studies further increase the evidence that contrast-enhanced MRA has high accuracy for identifying or excluding clinically relevant arterial steno-occlusions in adults with peripheral artery disease symptoms. In the overall sensitivity, 95%, specificity, 96%. And our esteemed moderator, Dr. Leiner, did an enormous tour de force comparing MRA and duplex ultrasound in the same group of patients using DSA as a gold standard, 152 patients, showing the superiority of contrast MRA compared to duplex ultrasound with higher sensitivity and higher specificity and higher accuracy. Now let's look at CTA. And this is a review published in JAMA 2009. Here, the data synthesis, I'm going to blow this up for you. The CTA, although the sensitivity and specificity were fairly good, not as good as contrast MRA, better than ultrasound. But the article concluded that the quality of the papers, mostly retrospective reviews, was poor and only supports use for intermittent claudication. I quote, "Diagnostic performance of CTA in patients with critical limb ischemia has been poorly investigated thus far." And they also noted a radiation dose, typically 12 to 14 millisieverts. That's pretty high. Here, from that 2009 JAMA review, an illustration showing how calcifications in the wall of the vessels obscures evaluation, making it more difficult to assess severity of disease. Another point that has come up is in the use of iodinated contrast, which can cause acute kidney injury, contrast nephropathy. And just last year in the Journal of Nephrology, this paper looking at 250 patients having iodinated contrast for DSA, nearly 10%, 22 of those patients developed contrast nephropathy, another potential risk of the iodinated contrast-based techniques. Now, finally, the British Medical Journal, one of the latest reviews, comparing MRA, ultrasound, and CTA, concluding MRA has the highest sensitivity and specificity, higher than CTA and higher than ultrasound. And I quote from the abstract, "Contrast-enhanced MRA seems to be more specific than CTA and more sensitive than duplex ultrasound and was generally preferred by patients." So in the body of existing literature that I've reviewed here, which doesn't include actually the ability to do higher resolution imaging with steady state, shows that already contrast MRA is established, and the meta-analyses describe contrast MRA as a technique of choice. Ultrasound has issues of operator dependence, It's limited in the pelvis, where bowel gas air can interfere with visualization of deeper vessels. CTA is degraded when there are mural calcifications, very common in diabetics and older patients with peripheral vascular disease. And it has the issues of nephrotoxicity and radiation exposure, and the same technical challenges that MRA faces with regard to bolus timing and venous contamination. Thank you very much.
And I'd like to thank Lantheus for inviting me to speak in this presentation. I'd like to share with you a little bit about what Ablavar is and what makes it so unique and different compared to the other gadolinium compounds that have been available for many, many years and the ones you're accustomed to using. I know some of you may have already been using the agent or have heard about it, but I'd like to really emphasize some of the unique features. So Ablavar, like all the other compounds, is a gadolinium-based agent. But what makes it so unique is that upon injection, this agent binds reversibly to human serum albumin. And this allows several possibilities for us. First of all, it allows the agent to stay in the blood pool for a much longer period of time than any other agent, which typically, when you inject, will stay in the vascular space for a short period of time and then end up in the extracellular space. And by doing so, by staying in the blood pool, what we have is an agent with significantly increased magnetic resonance relaxivity and T1 shortening effect of water protons, resulting in a boost in signal in the blood vessels. This is the first FDA-approved contrast agent for MRA, for evaluation of aortoiliac occlusive disease. It was approved in the US in 2010. It has been used in Europe in the past, known as the agent Vasovist. And it is indicated, again, as mentioned earlier, for the evaluation of aortoiliac occlusive disease in adults. The contraindications is a prior allergy to a gadolinium compound, and of course, in situations where patients have low eGFRs, careful screening has to be performed, and a risk-benefit analysis would have to be assessed, as with any contrast agent, in terms of whether we're going to administer a gadolinium product. The agent is ionic. It is linear, it is low osmolar, low viscosity. It has very high thermodynamic conditional stability, so it is a stable compound. It's excreted by the kidneys with about 94% of the agent excreted in the first 72 hours. It's not metabolized. The bulk of the excretion goes through the GU system, with a small amount going through the GI tract. So what does this agent look like, and what makes it so unique? Well, this is a schematic diagram of the agents. You have your gadolinium, which is chelated, as all agents are, to facilitate biodistribution and elimination. And then you have this phosphate diester bridge, which links the gadolinium component to this diphenocyclohexyl group, which is what is going to be binding reversibly to human serum albumin. So what does this give us? What does this allow us to do with this agent? Well, again, we have increased relaxivity. This allows us to lower the dose significantly. In fact, this agent is approved for 0.03 millimole per kilogram dosing. It allows us to, in addition to doing first-pass imaging, your standard first-pass MRA imaging, allows us to do steady-state imaging. And at that point, we can increase our spatial resolution to obtain submillimetric images in order to really evaluate and get more detailed imaging of the vascular trait. And of course, it increases the signal intensity of blood. This agent has the highest relaxivity in the blood pool of any gadolinium compound. So when we administer this agent, when we inject the agent, it is kept in the blood pool. It is bound to human serum albumin reversibly. So there's a small amount of agent that will be non-bound, that will be excreted by the kidneys. And if we look at different points after injection, we can see that at 0.05 and up to 4 hours after injection, somewhere between 80 to 87% of the Ablavar is plasma bound. And again, in equilibrium with a small amount of free Ablavar that will be excreted by the kidneys. Now, in terms of the dosing, how did we arrive at this low dose of 0.03 millimole per kilogram? Well, in this study, the phase 2 data from Pearl published in Radiology, this was a randomized double-blind study where they looked at contrast-enhanced MRA with Ablavar, comparing it to 2D time-of-flight MRA, and X-ray angiography was considered the benchmark. And they looked at different doses from 0.005 up to 0.07. And they found in this study that at 0.03 millimole per kilogram, there was an increase of 20% in diagnostic accuracy over non-contrast time-of-flight MRA. At any higher doses, it wasn't found to be any more efficacious and more accurate. So this is where the 0.03 millimole per kilogram comes from. In terms of adverse events, it has a very similar safety profile to the other gadolinium chelates that you've been accustomed to using, and they're available in a multi-center phase 3 study. There were some minor common side effects, including feeling hot, about 4.4%, nausea, headache, and a burning sensation on injection. There were 4 serious adverse events, but they were not deemed to be related to contrast medium injection. So what are the benefits of Ablavar relative to what you've been doing in the past? Well, again, the fact that you can do, in addition to your traditional first-pass imaging, where the image's quality is just as good, if not better, than what we see with conventional agents, the extended intravascular time within the blood pool allows you to do steady-state imaging. So at about 5 to 7 minutes post-injection, there is opportunity to adjust your parameters to increase your resolution, your phase over sampling, your matrices, in order to obtain high-resolution imaging and get potentially more anatomic detail in looking at the aortoiliac system. And this is attributable, again, to the reversible binding with urine albumin, which gives the agent very high relaxivity. This trial was from the phase 3 data from Goyen, and what this demonstrated was a look at Ablavar against time-of-flight MRA with X-ray angiography or DSA as the benchmark. And what they found is that when comparing time-of-flight imaging to contrast-enhanced MRA with Ablavar, the studies agreed more significantly with DSA with the Ablavar, 84% of the time in terms of the degree of stenosis, and there was agreement with X-ray angiography 92% of the time in terms of the location of stenosis as compared to time of flight where only 72% of the time there was agreement with the degree of stenosis. So what does this mean to you, the practicing radiologist, in terms of how you evaluate patients with aortoiliac disease? Well, there are a couple of advantages and opportunities with this agent. First of all, again, the ability to do steady-state imaging allows you to have a second opportunity to look at the vascular tree in situations where patients are uncooperative. So if you have a situation where you have a patient who's uncooperative, who's in a lot of pain from peripheral vascular disease or critical leg ischemia, there is opportunity, if you miss the bolus, to be able to go back and still salvage the examination and get a good quality exam without having to repeat at a later time with another dose of contrast and using more magnet time. Again, high-resolution imaging will permit more anatomic detail, which may potentially change your diagnosis and management of the patient. And it could be used in preoperative arterial mapping of the aortoiliac tree. Limitations, again, potential venous contamination, although not really an issue because you still have your first-pass imaging, which should be a clean arterial pass if your timing is accurate. Of course, there's the potential risk for NSF in patients with low GFR, and for this, as in my practice, we must screen the patients very carefully when evaluating patients with lower GFRs. So in summary, what I hope you can take away from this is that Ablavar is the first FDA-approved contrast agent for evaluation of the aortoiliac system for vascular imaging. It is a blood pool agent. In terms of scanning patients, the learning curve is not very steep in terms of adjusting your parameters. You don't need anything sophisticated or high-end in terms of your magnet or your software to do these type of studies. You get bright, high-quality first-pass imaging as well as steady-state imaging, which can potentially alter your diagnosis and help change patient management. Thank you for your attention.
Good evening, ladies and gentlemen. It's a pleasure to be here and be able to talk to you about this exciting contrast agent. What I'm going to do is I'm going to go through first-pass imaging of aortoiliac disease with extracellular agents, sort of how we do it and why we do it. And then we'll talk a little bit about imaging of aortoiliac occlusive disease with blood pool agents, talking a little bit about what makes it different, and talk about opening some new possibilities as far as how we do the imaging and how we interpret things. And we'll take a few looks at the literature along the way. So first-pass imaging for aortoiliac disease is performed quite often, as Dr. Prince mentioned, with MRA. We're very It's a very robust and very established technique used for the evaluation of aneurysms, occlusive disease, dissection, interventional planning, as well as follow-up. And what we do is we do dynamic first-pass imaging with a 3D gradient echo sequence with an extracellular gadolinium agent, typically 0.1 millimoles per kilo. Of course, in the first pass, we're constrained in the abdomen by certain considerations, such as how long a patient can hold their breath, and just the fact that we have contrast, which is following a profile, meaning it flows in and it flows back out, and that in of itself can cause some artifacts and some limitations on the resolution we can achieve. There's also limitations on how much volume coverage you can have during that first pass. Here are some example upper station or aortoiliac MRAs done with extracellular agents at my institution. And here's a study that was done quite recently that's a very large study looking at extracellular agent and comparing it with DSA. This was done by Bowie et al. It was a multi-center phase 3 study looking at 333 patients between 2004 and 2006, all of whom received single-dose gadodiamide or Omniscan, the endpoint being looking at the sensitivity and specificity to detect stenoses of greater than 50% using DSA comparison with 3 blinded readers. Here are a couple of images from this paper, and what the readers came up with is a sensitivity between 80 and 88% and a specificity of 73 to 92%, which I think are good numbers, but they're not what I'd call stellar. And what I mean by that is there's definitely room to improve aortoiliac imaging. MRA, contrast-enhanced MRA is a powerful technique, but it is not perfect. And what we're always trying to do is to look for ways to improve our imaging, improve our diagnostic capabilities. This is an example of sort of just what I would consider a very nice case here. It's done with an extracellular agent, 1.2 by 1.5 by 2 millimeter, which is about as high a resolution as I could get at the time, given constraints of breath holding. And it's a very nice image, and you can see this dissection. You can see it going retrograde. You can see it going antegrade. But as you start zooming up, you realize that there are certainly resolution limitations causing blurring and that sort of thing. So very nice image, but still somewhat limited. Now, looking at extracellular agents beyond the first pass, there is some utility in doing that, but you need to realize that the intravascular half-life for the extracellular agents is very short, ranging from 4 to 14 minutes. And in many cases, a very large percentage, up to in some tissues, 40% of extracellular agents comes out of through capillaries during the first pass. So there's a very rapid one-to-one equilibration between the extracellular and the intravascular space. So this is just showing here a 30-second delay, and from here the image quality continues to deteriorate with extracellular agents. Now you've heard about gadophosphosate trisodium, or Ablavar, which is approved for aortoiliac occlusive disease evaluation in patients with known or suspected aortoiliac disease. And the approved dose is much smaller. It's a 0.03, as Dr. Flyer mentioned, which is 30% the amount of gadolinium that we typically associate with a single dose of gadolinium. And this is due to its much higher relaxivity, about 4 times higher than that of extracellular agents in general, which gives it a total amount of injected relaxivity, actually a little bit more than a typical extracellular agent. So the first pass imaging, as was mentioned, can be done in a manner completely analogous to what you're used to doing with your first pass imaging, except that we're giving a smaller volume and you just kind of relatively decrease the injection rate. Then after that, you have a whole new avenue open to you, which is doing this steady state imaging. It's been shown you can do steady state imaging for up to an hour. The intravascular half-life of gadophosphosate trisodium is approximately 30 minutes. And this really does open new avenues, which I hope to demonstrate to you. Here are a couple of first pass aortoiliac examinations done with Ablavar, just to demonstrate that it looks quite similar, and in my opinion is quite similar for first pass. So what a blood pool agent brings to you is a sustained intravascular signal, and that's this blood pool property. It allows you to repeat imaging if something went wrong with the first pass. It allows you to support much higher resolution imaging, because we're no longer limited by constraints of that bolus passing through and of trying to capture the peak contrast concentration. We can just wait for the steady state to occur, several minutes, 20 minutes if you like, and go ahead and scan with much higher resolution using whatever type of technique you would like, but it's typically a very simple gradient echo technique, very similar to what we would do for the first pass, just with much higher resolution. And one of the things this allows you to do is to see beyond just the arteries. You can look at the lumen of the vessel, and you can also see plaque very interestingly. Here's an example case to sort of explain this. This is a 63-year-old smoker from our institution with suspected aortoiliac occlusive disease. And this is part of the study here, and this shows the upper station, and what you see here is tandem stenoses in the right common femoral artery, and it looks like we have a left common femoral artery occlusion. This is the first pass, and that would probably be my diagnosis at that point. Then we can look at steady state imaging. So this is 1 by 0.9 by 0.9 millimeter resolution through the femoral vessels. And you can see this black material here outlined very nicely by the arterial lumen. And that is the plaque that you can see in a delayed phase, something we're not completely used to seeing, but it kind of adds a new perspective to what we're looking at. And of course, since we're doing high isotropic resolution, we can see the plaque, and we can look at it in different planes as well. So here we have an axial reformation, and you can see this semi-lunar shape of a very eccentric plaque and a very compressed lumen, and I think we have a much better idea of how severe this stenosis is. And looking at that second stenosis as well, we're looking at both of them here, and you can see the second stenosis, which, you know, in the limitations of the resolution we get at first pass, you know, a lot of times we're not completely accurate. That's one reason, as great as we think we do with first pass, we're not perfect, and that's what the literature says. Well, this gives us a way to look at these occluded areas with much more sensitivity. Now, what's very interesting about this case is this is now a little bit of ancillary finding, but looking at the second station a little bit of this study, you can see that the common femoral artery appears occluded, and there it is proximal to the occlusion. Here it is at the occlusion. You can see it's completely dark. This is the vein. And then below, we can see that the superficial femoral artery has filled. If I were reading this on my first pass, I would, you know, this came out to be what I would have considered a pretty good study. The left common femoral artery was clearly occluded. And then I think there's very severe disease in the proximal left superficial femoral artery, probably reconstituting distally via these collaterals and very severely diseased at this point. So let's look at what the steady state imaging showed us here. So what I've got here is a MIP kind of curved planar reformat. And you can see this is the occlusion that we saw in the common femoral artery. And as we look distally at this superficial femoral artery, surprise, it's actually quite normal. And what we're seeing here is a focal occlusion and incomplete filling of that superficial femoral artery. And this really changed the potential management for this patient from a bypass procedure to a simple open endarterectomy of this one area of clot. So this is the kind of thing that we are able to see. This has been shown in the literature as well. This is a paper by Hadazadeh that came out in 2008, 27 patients looking at aorto-occlusive disease using single-dose gatophosphosate, comparing it with DSA. They looked at just the first pass, and then they looked at just the steady state. And what they found is in 74% of patients, at least one vessel, and many times more, differed in grade of stenosis between steady state and first pass. As a matter of fact, first pass tended to overestimate the stenosis grade in 28 segments and underestimate it in 15 segments, whereas steady state MRA, with its higher resolution, exactly matched DSA in all 334 vessels. So here's first pass, for instance, 14.7% were called occluded on first pass, whereas 11.7% were on steady state, which is the exact number that DSA came up with. Here's a quick example from that. So you can see this kind of stenosis here, which doesn't really catch your eye too well because it's a very eccentric stenosis, like a lot of these are, and it's nice to have the resolution to really be able to see them. On first pass, we're a little bit limited in resolution, but you can get an idea of the eccentricity of this stenosis. But with a high-resolution steady-state blood pool image, you can see the stenosis to much greater advantage, and then this correlates quite nicely with the DSA. This is just to show you the effects of resolution from a study that here's 1 millimeter resolution going to 0.8 millimeter, going to 0.5 millimeter isotropic resolution, and the amount of signal intensity is there to support high-resolution imaging is kind of the point of this, and it just depends on how high you care to go. In the aortoiliac, usually about 0.9 millimeter works pretty nicely. I'll just kind of leave you that this is just a very typical, about a 4-minute scan that you do, and you can see very nicely the plaque and the extensive amount of plaque, which is really not terribly obvious when you often look at luminograms that we're used to seeing. So a lot of other interesting information that we're learning and being able to see in aortoiliac occlusive disease. So in summary, Ablavar, or gadophosphosette trisodium, is effective for first-pass MRA of aortoiliac occlusive disease. It has a very similar net amount of relaxivity to an extracellular agent at its standard dose, but then it adds a new dimension as far as being able to do delayed steady-state imaging, higher resolution, to better grade stenoses as compared to first-pass imaging, and better correlation with DSA. And with that, I will thank you and take my seat again, and we'll continue. Thank you.
Now I'd like to get started with the panel discussion. And we have a number of questions, but if the audience has any questions, please feel free to bring them to our attention and use the microphone then. But the first question I have for the panel is, how are patients with known or suspected peripheral vascular disease imaged today at your institution? We learned from the first talk by Dr. Prince that there are differing practice patterns, but I would like to hear from these experts what is being done and how that has changed over the past 5 years and why that has changed. So perhaps Dr. Prince can be the first to answer.
Yeah, happy to. As Dr. Carr mentioned, we're now using the gadophosphosette with the bolus chase technique. And we always follow that with the high-resolution steady-state imaging. We're using the GE equipment. Instead of using the Vibe, we use the Lava. I run it at a 512 by 512 matrix, 2 to 3 millimeter slice thickness. It does take maybe 3 minutes per station. So it does take some time, and there is some respiratory motion in the top station. But I also agree that the fat saturation helps to make it easier to see the vessels. I've tried it without the fat saturation. It goes a tiny bit faster. And I've noticed that the referring physicians, when they look at the images, they're much more accepting of the fat-suppressed images. Occasionally, we'll have a problem with metal artifact and the Lava won't work, so we'll have to revert to the other approach.
Have you seen a switch from other imaging modalities back to MRA with the improved quality?
Yeah, I mean, I think there was a kind of a lull during the height of NSF where a lot of peripheral vascular MRA was shifting to other modalities, especially CTA. And it feels like it's starting to come back now.
Okay. How about you, Dr. Flyer?
Our workup of peripheral vascular disease is kind of also wiffle-waffle to some degree with NSF several years ago with its description and high concern about it. And the bulk of our workup really is done after vascular surgery sees the patient. Usually they have a full workup by vascular surgery in their lab with duplex ultrasound, and then it's left to us usually in terms of whether we're going to do CTA or MRA. And it becomes very, very patient dependent. We have a population of patients that have severe renal disease, and in those situations, we're kind of really caught between a rock and a hard place as to whether we're going to do one versus the other. If the patients are on permanent dialysis, they're getting CTA. If the patients are not on permanent dialysis, we're kind of really stuck in terms of what to do. It becomes a risk-benefit analysis. But we've certainly, over the last year, have migrated towards using Ablavar in cases where the GFR at our institution, our cutoff is 30, and and above 30, we've been imaging with that, and we found that the steady-state images has had huge advantages for us, and especially for the patient. A lot of these patients are elderly, multiple medical problems. Sometimes they have a hard time holding still because of leg pain, and really it's very difficult with first-pass imaging alone to sometimes establish a diagnosis, but the ability to do steady-state imaging, if necessary, to take them out of the magnet, to talk to them, to try to make them more comfortable, reposition them, and then rescan, has certainly saved us in many scenarios and helped us to establish a diagnosis. So it has been really, really useful, but I guess the only thing I can say is that in those situations where we have patients who are not on dialysis, who have severe renal dysfunction, we're still in a real dilemma as to what to do.
Thank you. Dr. Mackey?
Well, the institution where I do most of my vascular work is the VA hospital, and that is a great place to find lots of vasculopathic patients. For the last 10 years or so, we've pretty much relied exclusively on MR angiography for the workup of our patients with peripheral vascular disease, and we've done a lot of research and really attempted ways to try to improve the technique. And our vascular surgeons and our interventional radiologists have become quite enamored with our techniques and trust it pretty explicitly, and we've done a pretty good job along the way. CTA we've kind of dabbled in a little bit, but in this population in particular, there's a high incidence of diabetes, a lot of peripheral calcification, and vascular surgeons really need to know where the target landing vessels are, and that can sometimes be really hard to tell with CT, particularly when there's a lot of calcification. So to me, that's one of the things I like the best about MRA in general, is that we don't have to worry about calcification, we don't have to worry about the bones. I know there are a lot of institutions that do CTA as the first line modality for imaging. We've kind of gone away from that and gone to pretty much pure MR angiography. But in the last year or so, since Ablavar has become available, we have been using it more and more, and it's now to the point where the interventional radiologists are really noticing things such as the case that I showed, where it kind of makes you go back and wonder, what else have I been miscalling in the past? It gives you another window of higher resolution and at a time when you're in equilibrium and there can't be bolus effects or timing effects. And the interventional guys in particular, are really excited by this. So it's kind of changing the way we're doing things a little bit.
Dr. Carr?
Yeah, so similar experience. We use MRA primarily as the vascular imaging technique of choice and have done so probably for the last 10 years. We started using CTA about 3 years ago, I would say, mainly with the advent of multi-detector CT. But really the primary use for CT, in our hands at least, is for trauma, number one, so since the CT scanner is right there. And also, as Mark mentioned, for dialysis-dependent patients. Of course, they're probably the worst patients to do CTAs on because they tend to have arteries that look like concrete pipes, and they're almost nearly always end up with non-diagnostic studies. But primarily it's MRA. And so, initially when we started using Ablavar, that was always a concern. Suddenly you're introducing, an unknown into the equation. It disrupts the equilibrium of how you're trying to do things. But I can tell you, with the agent, there's there are not many additional things you have to do. You don't really have to change the protocol too much other than add these high-resolution images. And there are many situations where you really rely on these, and they've certainly rescued us a few times where we didn't need to call the patient back. And we are now imaging patients at multiple sites. I think many of the bigger institutions now have multiple sites or hospitals that they're imaging out of. And similar to Jeff, we do operate a little bit out of the VA, and where you don't have someone on site all the time, say, supervising studies.
What has been your practical experience when comparing first-pass imaging to steady-state imaging? Has it brought you new diagnostic capabilities? I think we touched upon that a little bit briefly, but maybe specifically now focus on that issue. Dr. Prince?
I think one of the very exciting things, of course, that high-resolution steady-state image, not just as a backup, but it shows that calcific plaque with some detail that you miss on the arterial phase. And some of our surgeons like to look for that and find good spots for landing a graft, a target site for anastomosis that's free of plaque. You feel like there's more information about the blood vessel. And so it's been treated with some enthusiasm.
Yeah, I'd like to make a comment as well regarding that. I think that one of the arguments that the surgeons always carry forward for requesting CTAs is that they can see the calcifications and determine the non-calcified segments for their interventional approaches. But if you look at the steady state information, you see these super black plaques, which also give you information about the calcifications that I think is quite useful. But yeah, Dr. Flyer, what has your experience been here?
Our experience has been very positive with the agent. We find that the steady state has a lot of utility, and as has been mentioned by my colleagues, it's just you really wonder what you potentially have been undercalling or potentially overcalling on first pass imaging now that you have the ability to scan in the steady state and see plaque better, to define the anatomy better, and to see smaller vessels. And we've had situations where it has definitely changed the diagnosis. And I think what's important is that what the vascular surgeons expect from radiology, and if you want the vascular surgeons to send these cases and be happy, is that they need good diagnostic information. They need to know inflow, they need to know outflow, they need to know where they can plug in. Interventionalists need to know where the length of stenosis, the size of the balloon and the stent up. So I think it's critical, and this is just an added dimension in terms of being able to scan at high resolution, to change your parameters. We also use the Siemens equipment. We use the Vibe sequence at 3 necks, at 512, and we do reconstructions as well. And I think between that information, doing reconstructions, interactive reconstructions on a workstation, it's very useful. I just want to say that I don't want anyone to think that at least in my experience, in every single case we've done, there's been a difference where Ablavar has changed the diagnosis. In many situations, it has completely been concordant with the first pass imaging, but we've had a whole slew of cases where there's been situations where we've underestimated or overestimated disease on the first pass imaging. So certainly, I couldn't see going backwards at this point to just using a conventional extracellular agent, because there's just too much information to be potentially gained by having that steady state available, especially in this patient population. And again, also bearing in mind that a lot of these patients have multisystemic disease and are not that cooperative and are uncomfortable and are in a lot of pain. So again, the ability to have that potential to scan at 7 minutes out to an hour is great. It saves magnet time, it saves additional doses of contrast load, cumulative dose. It's a big issue for us.
Dr. Mackey?
I'll just make a couple of quick, brief points. I agree with what both my colleagues say here. Just from my personal experience from having used this agent many times and looking just at the first pass, I would call it very equivalent to any other agent that I use for first pass. So the first pass imaging is what you're used to. There's nothing real different about it. The way I then go about interpreting my studies is I look at the first pass, and if it's normal, if it's clearly normal on the first pass, it's normal. And then what you've done is you've invested 3 or 4 minutes per station, so maybe 10, 12 minutes, something like that, in getting these high-resolution steady-state images, which, of course, as has been mentioned, can save you if you have a timing problem or if a motion problem or something. And I will then look at those. I will look targetedly at the areas that I'm seeing on my first pass that I have questions about, like in the case I showed you, where you're, a lot of times we look at things and we say, oh, it's a 30 or 40% stenosis, and you look at it on a much higher resolution image and you realize it's a 60 or 70% stenosis. So that makes the reading not as painful as you may think to go back and look, because we really don't look at every single cubic millimeter of every single vessel. We really, at least I, tend to target in on what I need to see to help make that diagnosis better. Just make that comment.
Before we finish off, I'd like to summarize with some impressions that I take away from this panel. So first of all, I think there's overwhelming evidence that MRA is a reliable tool for imaging peripheral vascular disease. And for other imaging modalities, as we've seen, there is much less evidence. So I think that's a very important learning point that I take away from this evening. Also, adding the steady state improves the diagnostic accuracy, and this is not a subjective experience, but we saw that in a number of publications. So that's an important point, in my opinion, and I think now we have a lot of evidence to show our referring clinicians that MRA is indeed a very safe and the preferred modality for imaging patients with suspected aortoiliac peripheral vascular disease. So with that, I'd like to thank you also, the audience, for coming to the program, and Lantheus for making this possible. Thank you.